All right, so now we're going to cover the pharmacology of depression. We're kind of going through this by pathologies rather than by drug classes, so we are going to see some overlap from time to time. That may not be the best way to do it, but that's kind of the way this book separates it, so that's what we're going to do. So first of all, depression characterized by a sad or despondent mood. So we all kind of have an idea of what depression is. We've all probably been a little bit depressed from time to time. So when we talk about depressive disorder, we're talking about something different, but it's kind of a degree of the same thing with maybe more symptoms involved. So many associated symptoms: lack of energy, sleep disturbances, abnormal eating patterns, feelings of despair, guilt, hopelessness. It is the most common mental health disorder of older adults, so make note of that, older adults, and may require hospitalization with suicide precautions, close observation, um, at least until medications reach their peak effect. So I guess another take-home would be that suicide is a very real thing, and so depression can actually lead to death, death by suicide. So this isn't something that's benign and people are just sad. It can end tragically. So it's believed that depression is caused by a lower level of monoamine. So if we think about what happens in the brain, this kind of becomes important. You need to know what monoamines are. Maybe not all of the details. An amine group is usually just like a nitrogen-containing group, like amino acid. You see that word every now and then. Monoamine just means that it has one of these, and that's common for serotonin, norepinephrine, and dopamine. Okay, so these are all made from different amino acids, and so it kind of makes sense. And so as long as you remember, when you see the word monoamine, you should be thinking of at least these three neurotransmitters. Now, primarily what we're talking about is serotonin, and I have over here a brain, and it shows some serotonin pathways, and most of them originate kind of down here in the brainstem midbrain area. But they go all over the brain, and it was kind of a big discovery when we figured out that decreased serotonin or lower brain serotonin levels were associated with depression. And one of the ways that was done is that drugs that increase serotonin levels seem to alleviate depression. Okay, so it depends largely on the response of the patient, because of course, I'm going to say that throughout, different patients handle things differently. They react to different medications differently. All right, so major depressive disorder. This is types of depression. Major depressive disorder, diagnosed of a depressed affect, or which kind of means mood, plus 5 of the following symptoms for a minimum of 2 weeks. So sleeping disturbances, so either difficulty or sleeping too much, extremely tired, no energy, abnormal eating patterns, so it can even manifest as like pain, GI, joint, or muscle pain, inability to concentrate or make decisions, feelings of despair, guilt, lack of self-worth, miserable, which I assume is miser, obsessed with death, expressing a wish to die or commit suicide. Now that seems like a red flag right there. Avoiding psychosocial and interpersonal interactions, delusions, or hallucinations. So that can even be experienced as one of the criteria of depression. Okay, so 5 of those, at least 5 of those, lasting up to last a minimum of 2 weeks. So there are other forms of depression, postpartum depression, which is really hormonal. It's caused by hormonal changes after giving birth. It may be treated with regular antidepressant medications. But it's hormonal changes after giving birth. Seasonal affective disorder, also called SAD. Enhanced release of melatonin due to lower natural light levels. So remember, 5-HT means serotonin, but serotonin and melatonin are kind of structurally related, and their pathway, the pathway to produce these, are they kind of rely on one another. Okay, so to make that very, very simple, they kind of occur together. So it kind of makes sense, kind of fits with that serotonin idea for depression. So psychotic depression, intense mood shifts, unusual behaviors. So bipolar disorder, which we'll cover in a completely different section, has a depression component to it as well. So treatment. Well, we're talking about drug treatments here, but most severe depressive illness generally requires both medication and psychotherapy. So you have to have some kind of counseling therapy, cognitive behavioral, psychodynamic therapies, something else aside from the medication. And it goes the other way too. You can't, a lot of times, just cognitive behavioral therapies won't work without some kind of medication to complement those. So they kind of work together. Some drugs or some patients are not, drugs don't work. Okay, so drugs don't work, and nothing seems to help the psychotherapy and drugs. And so there is an option of electroconvulsive therapy in those that are unresponsive to pharmacotherapy. It sounds barbaric, but it actually is still used, and it's been shown to work. Okay, so yeah, so pharmacological treatments are composed of several classes. We're going to go through drugs and examples of drugs for each one of these. SSRIs, which we've talked about already. SNRIs, so now we're adding a norepinephrine component. Tricyclics, which are kind of older, and they really work very similarly to SNRIs. There are a few differences that we'll get into. And then atypicals, which have a whole bunch of different types of mechanisms. So we'll cover the mechanism for our prototype. And then MAOIs, monoamine oxidase inhibitors. So MAOI. A lot of times that I is lowercase. But monoamine oxidase inhibitors are, we'll get into that mechanism as well. So I have a note here, and it says St. John's wort is an herbal remedy that people often use to treat depression. So St. John's wort is available. You can buy it at a store where they sell herbal remedies. And it actually works in many of the same ways. It does have some of the same properties as many of these drugs. So it can increase serotonin levels, which is the real problem, also norepinephrine. And so it's really important that you know if your patient is taking St. John's wort, because it can have interactions. So that can really cause a problem like serotonin syndrome or something like that. So keep that in mind and check to see if St. John's wort is listed as as an interaction. All right, so SSRIs. So we'll try to go through this quickly. Fluoxetine is the prototype. I think we already talked about escitalopram, or sertraline. And so fluoxetine is the prototype drug for SSRIs, which is Prozac. And then there are these others that are listed here. And it's kind of in the names, selective serotonin reuptake inhibitors. It selectively and specifically inhibits the reuptake of serotonin. So normally serotonin is released and then it's taken back up into the presynaptic terminal. Well, if you block that, then all that serotonin has to stay in the synaptic cleft, where it activates that receptor more. Okay, so it increases or enhances the effect of serotonin after it's released. Okay, so SSRIs are considered the first line of treatment for depression. Okay, and that kind of makes sense because it's selective for serotonin, and if that works, then that's fine, and they're shown to be pretty effective. So largely took the place of tricyclics because SSRIs are better tolerated and safer in an overdose. So that's another reason. So it may take 1 to 3 weeks or longer before pharmacological benefits take effect. That's in purple, so it's kind of important. Not that everything isn't important, but that's something to keep in mind, especially when because your patient shouldn't expect to feel better the next day. It takes a little while for it to get to that therapeutic level. So other drugs such as bupropion, which we'll talk about, it's an atypical antidepressant, may be used as adjuncts. Now the thing about bupropion is it works on dopamine and norepinephrine. So it doesn't work on serotonin, so it can complement the serotonin effects of SSRIs without actually interfering and adding to the effect. All right, so the prototype, fluoxetine, which is Prozac, mechanism selectively blocks reuptake of serotonin, so it's an SSRI. And primary therapeutic use, major depression and also anxiety disorders. And I didn't put all of them here, but there's a range of anxiety disorders that it can be used to treat. Adverse effects. So this is a big one. Sexual dysfunction. So this is a lot of times a reason why people want to stop taking SSRIs. So anorgasmia, which means that either delayed orgasm or a lack of orgasm, impotence, decreased libido. These can be very, very discouraging to some people. So may need to adjust the dose or replace with a different antidepressant. So like the bupropion, that's not that is less likely to cause the sexual dysfunction. So CNS stimulation is another adverse effect of SSRIs, so you would advise someone to take it in the morning and avoid caffeine. Weight loss followed by weight gain. So this can be a problem. So that's another discouraging thing for patients when they start to gain weight. That's kind of aversive and kind of a reason why they don't maybe want to stay on it. Okay, so that's something else to kind of monitor. So GI bleeding, remember, serotonin is also found in blood platelets. I think I said red blood cells before, but it's found in blood platelets, which are involved in clotting. And so the thing to do here with GI bleeding makes sense, but it also involves drug interactions, especially anticoagulants, including NSAIDs. Remember, NSAIDs can kind of inhibit clotting as well. So keep that in mind when you're going through the drug interactions. Serotonin syndrome. Okay, we talked about that a little bit before, but serotonin syndrome, it's that serotonin toxicity, which is too much serotonin in the brain. Makes sense. You're blocking the reuptake, you're leaving more in the synapses. It has a heightened effect. And in some people, they may experience toxicity from this. Oftentimes confused with drug withdrawal, so it's a lot of times hard to recognize. In fact, that can be a problem. It's more common with MAOIs, especially people who are also taking MAOIs. It occurs rapidly within 72 hours of administration, but it doesn't have to. Okay, so it's not, oh, it's been 73 hours. That's not what it is. But that's commonly when you might see it. And I think of up things like tremor, agitation, hyperreflexia, those kinds of symptoms. Fever, which is also up, it's just temperature. Agitation again. Confusion, and it usually resolves when the medication is discontinued. So if you stop giving the SSRI in this case, then it should alleviate itself after a while. However, there are antagonists that you can give to stop it. There are benzodiazepines you can use to treat the symptoms, that kind of thing. All right. SNRIs. So now we have serotonin-norepinephrine reuptake inhibitors, and it's just that. So we had inhibition of serotonin reuptake over here, which left more serotonin, and now we also have inhibition of norepinephrine, which leaves more norepinephrine. So it's working selectively on both of these neurotransmitter systems, which can be good, right? Because now we have norepinephrine, so it may treat a wider range of symptoms. However, this is kind of how it helps to know these things. Involvement of norepinephrine is also going to lead to other side effects like increased blood pressure and heart rate. So you're going to be wanting to kind of look for that as a possible adverse effect. So therapeutic effects are similar to SSRIs, but sometimes they're more effective. It really, again, depends on the person. Okay, so the prototype drug venlafaxine, Effexor, mechanism, it specifically blocks reuptake of norepi and serotonin. Primary therapeutic use, major depression, and then this range of anxiety disorders, but it's also has an unlabeled use in some SNRIs. This is actually labeled for them, but not in the case of venlafaxine. Unlabeled use for pain due to fibromyalgia, osteoarthritis, low back pain, diabetic neuropathy. Okay, so that's something else to kind of keep in the back of your mind there. So adverse effects. Nausea, anorexia, weight loss. Okay, so now we've got that norepinephrine involvement, and that norepinephrine can actually lead to weight loss, anorexia. Headache, insomnia, and headache, only need one of those. Hypertension, tachycardia, again, that's going to be the involvement of the norepinephrine, same with dizziness and blurred vision, which we'll kind of talk more about later when we talk about anticholinergic effects. Withdrawal may occur. Risk for suicide in children and adolescents. So that's some of that suicidal ideology. And and some of these people are already suicidal or, you know, right there at the cusp, and this can push them one way or the other. Hopefully it works as an antidepressant, but in some people it could push them the other way. It's really hard to tell, and some people question that because you're dealing with a patient that may already be suicidal. So sexual dysfunction does exist. The same kinds of things we saw with the SSRIs. Anorgasmia, decreased libido, impotence, menstrual changes is also included in the list here. Serotonin syndrome, so you can go back and look at that, and then also bronchitis and dyspnea. All right, so let's look at these atypical. So the research is still continuing for depression treatments because it doesn't work with everybody, and they aren't perfect. We're constantly trying to reduce side effects. So the example, and this is your prototype, bupropion, vilazodone, mirtazapine, reboxetine, trazodone is another one. We can't really point to a mechanism because that's why these are atypical, is they all have slightly different mechanisms that don't really match up with any of the other drug categories. That's why they're pushed into this category of atypical. We will talk about bupropion. Most of these do increase serotonin. Okay, so they do have some effect. Most of these do have some effect on increasing serotonin. Bupropion is kind of an exception, and it's specific to blocking the reuptake of norepinephrine and dopamine, which is kind of important. Okay, so that's your prototype, bupropion. Wellbutrin, Zyban has other trade names. Mechanism of action blocks the reuptake of norepinephrine and dopamine. I'm going to say now that something else that blocks the reuptake of norepinephrine and dopamine is amphetamine and cocaine and, you know, your ADHD treatment drugs like Ritalin, methylphenidate. So these also block the reuptake, and originally this was thought of that maybe it would be effective against ADHD, but then they found that it was either more effective or it was effective against depression, and so that's a labeled use for it. Okay, so primary therapeutic use is major depression. It's an alternative choice for ADHD for that reason, because it kind of has that same mechanism that other ADHD drugs have. Used in patients unable to tolerate sexual dysfunction, so it doesn't have the sexual dysfunction side effect. That's kind of important because that might be the go-to for people that are experiencing that side effect. So adverse effects: headache, dry mouth, GI distress. So we're talking it's not labeled that way, but kind of talking about anticholinergic effects, kind of like your fight or flight kinds of things, at least the dry mouth anyway. Nausea, vomiting, anorexia, weight loss, so it's kind of an upper, okay? So that kind of makes sense. Constipation, again, that's more of a sympathetic type of thing. Increased heart rate, hypertension, so you can kind of see, again, these things are causing more up types of behavior. So restlessness, insomnia, and if you think about it, it kind of makes sense because it's, you know, I mean, cocaine does the same thing, but it works well on depression. Bupropion does, not cocaine. So yeah, so seizures, it can lead to an increase in seizures, so don't use in patients with seizure disorders. That kind of makes sense. All right, so the next category are tricyclics. So tricyclics are kind of an older group of antidepressants. They're named, I'll just jump down here, they're named because, tricycle, and you know, a tricycle has 3 wheels, and so you can see here that it has 3 wheels, it has 3 ring structures, and that's why it has its name. Examples: amitriptyline, that's the prototype; imipramine, nortriptyline, doxepin. There are a whole bunch of them up here. I don't want to read them all, but they really, okay, this is important. They're kind of like SNRIs in that they block the reuptake of norepinephrine and serotonin, and that's what's really causing their therapeutic effect, okay, is they block the reuptake of norepinephrine and serotonin. Now, they're grouped and categorized because of their structure, tricyclics, and they were around longer. The SNRIs came along later after the SSRIs. They started developing, they said, well, wait a minute, remember the tricyclics? They affected norepinephrine. Maybe we should try to do that too. Okay, so that's what this says. Older antidepressant largely replaced by SSRIs and SNRIs. Okay, so back to this. They do block the reuptake of norepinephrine and serotonin. However, they also partially block muscarinic acetylcholine receptors. Now I'm going to ask you to kind of remember back acetylcholine. Remember acetylcholine, especially the muscarinic acetylcholine receptors, are involved in the parasympathetic response, the rest and digest response. So we're blocking that. So what kinds of side effects do you think we might see? We might see sympathetic responses, fight or flight types of side effects. Okay, so I'm going to mention that again, but keep that in mind because this is one of the problems with tricyclics is they're not as clean as the SNRIs. They're also blocking acetylcholine receptors and histamine. And what does an antihistamine do? Knocks you out. So histamine, which may cause sedation. So now you have possible fight or flight symptoms or possible sedation that can kind of go along with these. But it doesn't, of course, happen in everybody. So most also block certain calcium channels, which can lead to cardiac toxicity. So when we cover the heart, we're going to talk about things like calcium channel blockers. And so this kind of makes sense. So the maximum effect takes even longer than SSRIs, may take 4 to 8 weeks, so a month to 2 months is how long it may take to have an effect. So let's look at this. The prototype drug amitriptyline, Elavil, blocks the reuptake of norepinephrine and serotonin. And then I wrote here, and normally this is all you'll see, blocks the reuptake of norepinephrine and serotonin. But I put here because it helps to remember the side effects. It also blocks acetylcholine and histamine receptors as well as other neurotransmitters. And really, what am I talking about there? The one that we could probably should remember, is the calcium, because that's going to clue us off to the fact that it can be cardiotoxic. Okay, so let's look at primary therapeutic use, depression. Depressive episodes of bipolar disorder as well. So let's look at the adverse effects. Orthostatic hypotension. So if you get up too fast, you can crash again. So that's something to be aware of, or if you're a caregiver, to be aware of. Anticholinergic effects. Okay, you have to understand this term. So it blocks that parasympathetic system, and your parasympathetic system is your rest and digest, so it can partially block that, leading to a sympathetic type of response. I know that can be confusing since we're calling it anticholinergic, but that's what it's doing. So if we just kind of switch around and we say, okay, what is a sympathetic response? We can say, well, dry mouth, because a wet mouth, if you're salivating, that means you're ready to eat and digest, okay? So a dry mouth would be the opposite of that. Blurred vision happens because your pupils dilate, okay, which is a sympathetic type of response. So blurred vision. Photophobia, same thing. Your pupils dilate with a sympathetic type of thing. So when you see anticholinergic, you should start thinking, okay, I'm going to start seeing sympathetic types of responses, and sure enough, that's what we see. Dry mouth, blurred vision, photophobia, urinary hesitancy. Well, parasympathetic is urination and defecation. So if you have sympathetic, you might expect to see urinary retention and constipation, which is another one. Sympathetic also would involve sweating, tachycardia. So all of these things kind of really make sense there. Sedation. Now the sedation comes from from the antihistamine effect that happens in the brain. Okay, so that can cause the sedation and may diminish over time. Toxicity leading to cardiac dysrhythmias. So an overdose can lead to death because of the cardiac, because it's cardiotoxic. It can cause dysrhythmias and has an effect on the heart. And again, that comes really, you can think of it as coming back to the fact that it has an effect on those calcium channels. All right, and also a decreased seizure threshold. Okay, the last one. There's a lot to say about this one too. it's not that complicated. It's the monoamine oxidase inhibitors. Okay, so obviously there's something called monoamine oxidase, and obviously it's being inhibited. Monoamine oxidase. Okay, so if we kind of follow the same path we've been talking about. So we release, in this case, I'm over here on the left. So we release the monoamine, which in this case is norepinephrine. And then that norepinephrine is taken back up through that transporter, back up into the cell that just released it. Well, there's an enzyme sitting there waiting for it. Okay, it doesn't just get a free ride. There's an enzyme waiting for it that is going to break it down and then eject it. Okay, some of it may be repackaged, but some of it is broken down. What monoamine oxidase inhibitors do is they block that enzyme. Okay, so that means that the norepinephrine is not broken down, which means that you have more of it. Okay, so monoamine is very nonspecific, so it works with serotonin too. Good thing, right? Because we're talking about depression, and depression largely involves serotonin. Okay, so by blocking the blocking the monoamine oxidase enzyme, we're increasing serotonin levels, we're increasing norepinephrine levels, and we're increasing dopamine levels. It's just not on this graph or this picture. Okay, so and those are all your monoamines. Okay, so monoamine oxidase breaks down the monoamines, serotonin, dopamine, norepinephrine, in the presynaptic terminal, which will reduce their levels. That's what it does normally. The inhibitor blocks that enzyme, which will increase their levels. So you're going to have higher dopamine, higher norepinephrine, and higher serotonin. Okay. Now, there's one little thing here. I have tyramine, which is an amino acid. It's also broken down by MAO. That's going to be hugely important, the most important thing about monoamine oxidase inhibitors, because they are effective as a treatment for depression, and a lot of times they're used for depression that's resistant to other treatments, but there is a dietary restriction. Guess what that dietary restriction is? Things that have the enzyme tyramine, because tyramine also wants to be broken down by monoamine oxidase. It says, hey, I'm here, I want to be broken down too. And when it does, and when you have high levels of tyramine, guess what? Nothing gets broken down. Okay, so this norepinephrine, serotonin, these levels will start to increase because now you have another player in there. Now you have tyramine that's also trying to be broken down. So you already have inhibition, which has the levels raised a little. But now you've shut it down, I won't say completely, but now you have another competitor in there, which is going to cause the levels to go even higher. Okay? And what's the deal with norepinephrine? Norepinephrine can cause vasoconstriction, okay? Increased heart rate, and that's a problem. Okay? So so the patient has to avoid foods that have tyramine, or they could experience hypertensive crisis, and it makes sense because you're putting in something that's competing with all of them. Okay, so it's competing with serotonin, dopamine, and norepinephrine, but the norepinephrine causes the problem. So it competes with that norepinephrine. Norepinephrine levels build up, and then you have systemic vasoconstriction, which is going to cause hypertension. So you end up with hypertensive crisis. Okay, so when ingested, tyramine can compete with the monoamines at the MAO enzyme, leading to an increase in their concentration to toxic levels. Norepinephrine is the problem. It is a powerful vasoconstrictor leading to severe hypertension, tachycardia, and of course headache, diaphoresis. The big problem is the hypertensive crisis. All right, so if we look at the drug, this should all make sense now. The prototype drug, phenelzine, Nardil. Mechanism of action blocks the enzyme monoamine oxidase. It's called an MAOI, monoamine oxidase inhibitor, so that makes sense. Primary therapeutic use for depression, that's what we're talking about. It also can be used for bulimia nervosa and a range of anxiety disorders, so it can be used for anxiety as well. Adverse effects, CNS stimulation, agitation, mania, or hypomania. So we're talking about up types of things here. Orthostatic hypotension requires care and monitoring. This could be a blood pressure, so lower blood pressure issue. But where we really concern, and this is really one of the main things that that prevents the more psychiatrists, nurse practitioners, keeps them from prescribing it as much is because it can lead to hypertensive crisis if the people eat the wrong thing. Okay, so so the types of foods like certain types of fish, wine, certain chocolates, you can't eat those. So anything with and I didn't write them down here, but you can look those up. So certain foods with tyramine. Okay, and I could just read through this. It's saying the same thing I've said 3 or 4 times. Competition of tyramine at the MAOIS enzyme leads to high levels of norepinephrine that cannot be broken down, severe hypertension from vasoconstriction and heart stimulation, headache, and nausea. And that's it for depression.